Well, I think my talk more or less has been covered by the previous speakers, so I'll be brief. How do you move? Okay, why calcium matters? I think we have uh, heard a lot of speakers talking about calcium. One thing is very clear that more and more calcium we have to deal. Why? Because increasing age of people and more complex lesions we are doing now. More and more patients don't want surgery. In fact, now any patient who's more than 75, I think 3 times before sending him to surgery. So even the patients want that, and we also know that with increasing age, more diabetes, more kidney disease, calcium is very common in these patients. Roughly, if you see the pooled data, roughly 30% of the patients will have significant moderate to heavy calcification if you see various trials. And these are the lesion classification. Again, the complex lesions are increasing in PCA again because new technology and less and less acceptance by the patient for bypass surgery. So we also know that calcium leads to poor outcomes, and it's not a new information. So as far as possible, all the the endpoints, death, myocardial infarction, TVR, everything is more in these patients. And these are also again data from various trials to show that how in mild, moderate, severe calcification, how the results are getting bad. So one thing is very clear that when we have a calcium, first of all, I think most important thing is that the angiogram should be reviewed very thoroughly. We should sit on the angiogram, see very well, and not only sometimes you get angiograms from the peripheral centers where the angiogram is not up to the mark, so you should not decide on basis of that. You take another pictures in your own lab and then have a assessment of the lesion. And if you are plus minus that your moderate calcification, should I do developing, should I not do developing? I think one of the things which can help you is do imaging. But again, a caution is that you should do imaging if you know imaging. I've seen many people doing imaging, but hardly having really grasp of the imaging. So any technology, if you want to use for the benefit of the patient, you should have a very clear understanding of that technology. So if you think about the management, I think we have already talked about it. So there are imaging we have listened from the previous speakers. OCT to me looks a little bit better because it gives you more depth and study of the nodules than the IVS. But whatever technology you have in the lab, you must use to clarify these lesions and make a plan how to deal with these patients. So I think depending upon the degree and the arc, the length of this, you don't want only to know calcium, you want to know whether it is intimal, whether it is deep calcium, how much the length of the calcium, and whether it is nodule or no nodule. So all those things matter. And one thing which is worse in CAD is that if you have a calcification over a bend, that is the worst combination. There you have to be doubly, cautious to deal with these cases. So I think we have cutting balloons, we have scoring balloons, and we have the OPN balloons. We have the lithotripsy. These are balloon technologies. Then you have the ablative technology like rotational atherectomy, excimer laser. Just heard Praveen Chandra, and you have orbital. These are the balloons which you have heard. But these balloons work only in mild to moderate calcification, or they work when you have done some debulking. Then these balloons are more useful rather than just the single, technology to help you in these patients. So lithotripsy is another very good armamentarian we have got in the calcified lesion. The only thing is that the balloon, it will not go through in many of the tight lesions where you may have to use rotablation before using this technology. So I think everybody knows about these patients. I will just show you 2 cases rather than talking theoretically. I think this one case, 72 years of male post bypass surgery, Lima to LED, and he came with severe angina, and this is the lesion. heavily calcified, 90-degree bend, and we couldn't cross first with the, we tried BMW wire, but even the nano balloon will not go through. So then what to do? Fortunately, I got across the rota wire, and then we debulked with the rotablation. The first is 1.25 word. Took quite some time to cross this bend. It's not only immediately. See, the thing is, in rotablation, you have to be very, very patient. Never push. That's my philosophy. Never push the burr. Otherwise, if you push it, you will have a stuck burr. So after that, we did the imaging, which showed a lot of amount of calcium. Before that, there was no question of imaging because nothing was going. That's the picture in the IVUS. And then we did the 1.75 burr. Then we did the balloon dilatation. There was a distal lesion as well. This is, I think, we deployed the stent, dilated the left main area with a 4 into 15 atmospheres, and we got a very good result in this patient. This patient you could not do before without rotablation, and the best results will be if you use IVUS at the same time. We got very good MLA, the left main 12.57 and in the proximal circle 11.64 in this patient. This is a very interesting case. People have been talking about a stent, in-stent restenosis and how to deal with that. My thinking is that any stent, if you come to restenosis, first of all, if possible, study with IVUS or the OCT to understand the mechanism of restenosis. See, like this patient had a proximal LED stent, then he had another ACS. So somebody deployed the stent, and if you see carefully, the stent didn't dilate. You can see very clearly there is a dumbling in this patient. And in that process, he left the wire also, and the patient came next day with the unstable angina, and the stent had occluded. So cross with the wire, and believe me, even it was difficult to go with 1.5 new balloon, very hard to go through, and I used many balloons, fractured, I think almost like 8-9 balloons, OPN, 3 OPN balloons were, but this dumbbell will not go, it will remain as it is. So I didn't have IVL that time, but then I called the IVL people and they took some time to come. It was already 3 hours into the procedure. So did IVL, and after IVL, I was able to expand the stent. And then there was a question of this wire hanging there. Ultimately, I tried to remove this distal wire, but I could not. So I exteriorized with another stent and got a good result in this patient. So this is the final result of this patient, which is very acceptable. So the lesson from this patient is to anybody, particularly the beginners, don't deploy stent until and unless you have prepared the bed for it. And how to know about the bed, whether you are happy. One is the simple method is to see how the balloon expands, but more important will be if you can do after balloon dilatation, do the IVUS, that how your lesion has opened, whether it is ready for the acceptance of the stent or not. So this is ultimately, these are the kind of armamentarium which I had to use in this patient, and bill was very high in this patient. So in conclusion, significant coronary calcification is seen in 20 to 30% of the patients. A critical analysis of the angiogram should be done before planning PCI. I think just looking at the angiograms, to my mind, is very important rather than just jumping to the imaging. Imaging does help in these patients. A moderate calcification and a doubt of developing should be cleared by imaging, which acts as a guide for a plaque modification. In general, my philosophy is whenever you're thinking, should I use a debulking rota or not, use it rather than not using, because you will repent if you don't use. And I think it is not a good idea to produce dissections before you start rotablation. So rotablation should be known to every interventional cardiologist. I tell you why. Because you will find lesions where your IVL balloon will not go, or maybe then you may have to use a laser, but everybody doesn't have laser. So rotablation is something which is indispensable, according to me, to deal with calcium lesion. There is no doubt that imaging guided PCI of calcified lesion with proper developing gives better immediate and long-term results. Thank you very much for your attendance.
Thank you so much, Dr. Kler. That was an excellent talk. It was great to hear all the different evolving methods and methodologies that are there in the system today and all the armamentarium that you have. I was just wondering that, yes, we go to the OCT and the IVUS, but do you ever think of doing a CT before you start these patients, and whether non-invasive imaging? Because I do realize that now we're talking about plaque more than whether in stenosis or anything else.
Right,
And when we're talking about CT, we now can even tell between necrosis and intimal thickening with lipid to necrosis, which could actually lead to plaque rupture, and then calcification, extent of calcification, depth of calcification, and even the extent. So,
Well,
do you feel that CT would be of any use to these patients?
yes, CT will be very useful if you are doing a CTO, because you do not know the health of distal vessel and you cannot study these patients. If you have a CTO, CT angiogram, I think should be almost mandatory. But again, you should have capability of yourself assessing the CT. Don't depend only on the radiologist. You should know yourself how to interpret those pictures. As far as the imaging is concerned, if it's a very tight lesion, I don't, try to do imaging. If it goes very simply, I do it. Otherwise, I dilate or I do 1.2 fiber, then do imaging so that the patient is stable.
So I think the important thing is also that if you have a CT scan, you can definitely get it mapped into your interventional radiology suite, interventional cardiology suite, and then you can actually link the two so that you can take it as a railroading procedure, especially in the CTOs.
So in a CTO, for example, if you have if you have an uncrossable lesion, like Praveen Chandra was saying, the laser, if you know the anatomy by CT, you can direct your laser to cross the lesion. So that way it is very useful.
Great, thank you so much.
Fascinating discussion, but we'll have to cut it short for lack of time.
Yeah,
Thank
so
you very
I'm gonna
much.